and the role of anterior segment imaging post-glaucoma surgery.
Thank you, Purvi. So trabeculectomy still is the most effective filtering surgery, even though more and more surgical options now are available to us. Long-term success rate is very good. At the end of 15-year study, the 67% of the eyes were under control. This is the study which was done by Chen et al. And this graph is showing you that in the early phase, there is a steep fall in the success rate. And then there is a moderate cases which are showing the failure. And at the end of 20 months, there is hardly any failure. So if we can see, if we can do so in the early phase, then we can manipulate and we can prevent the failure of that trabeculectomy. Now we know that the bleb morphology is known to be an important indicator of the bleb function. Moorfield classification everyone is using. It gives us area of the bleb, maximum elevation, height, and the vascularity. While the Indiana bag morphology classification also includes the leakage of the Seidels positive in that bleb area and how much is the leak, one or multiple point leak or the sweating bleb. This all decides the success. And the latest one is the Mainz bleb appearance grading system, which also includes the vascularity of the bleb area and the transparency of the and the mobility of the bleb conjunctiva. These are also important factors for the success. So microcyst appearance, bleb transparency, and the conjunctival mobility is included only in the last one that I said. Now we know that the anterior segment OCT is a promising tool to image the trabeculectomy blebs. And it can demonstrate the features of bleb morphology which are not visible with this simple slit lamp. So these features of bleb morphology, which is not visible on the slit lamp and visible with the OCT, can help us in evaluating the functionality of the bleb in very, very early post-op period. This is a cross-sectional image of the bleb showing you a subconjunctival fluid space, bleb wall, then small cystic areas, anoic areas. Then this is the suprascleral fluid space, root beneath, and the sclerostomy opening, how big or how small it is, and the iridectomy. There are other features also that I will describe later on. The ideal bleb should have a vascularity of the bleb similar to the surrounding conjunctiva, numerous microcysts, diffuse bleb, and moderate elevation. So the anterior segment imaging can show us all three features which are important for the functioning, good functioning of the bleb, except vascularity. Now the same elevation, good leaking bleb can have a different features as shown in these three slides. One has a large cystic space, the other has a spongy look, and this has a various separated layers of the subconjunctival area. It could be a dyspeptic look on the slit lamp, avascular bleb, diffuse bleb with a large area, may not be always good functioning bleb. As shown in this, there is a hyperdense echoes in this area which is suggestive of fibroblastic activity. Eventually this bleb may fail. So cause of failure, we know that it could be a subconjunctival or suprascleral fibrotic area or the occlusion of the inner ostium that we have to look for doing the gonioscopy. So coming back to the first slide that I have shown, can we predict the early failure? Can we recognize early so that we can prevent the failure, and we can by managing it better by giving injections, or we can do the needling also at that time, or release the releasable suture. So the most important step in the management of failing bleb is to recognize its presence. And that is why we undertook this study to correlate the morphological feature of bleb on the anterior segment OCT at 1 month with the bleb function surgical success at the 6 months. The cross-sectional images were taken from the radial part as well as the tangential area of the bleb. So bleb wall reflectivity could be uniform reflectivity, or it could be multiform reflectivity. Uniform reflectivity usually is a sign of the failure, and the multiform reflectivity with the tiny cavities of the aqueous drainage is a sign of the success. Now, multiform bleb wall reflectivity again is divided into multiple internal layers as shown here, or it could be subconjunctival separation like this, or it could be multiple microcysts like this. So the last one, microcyst, is an ideal bleb and is always a 100% successful bleb. The root beneath can easily be identified using this technology. So you are sure that nothing is occluding the outflow facility. And this is the conclusion we had with our patient study, that if patient has a microcyst with the subconjunctival separation, it is showing 100% success at the end of 6 months. The OCT was performed at the end of 1 month of the surgery. So bleb wall with the multiform reflectivity shows increased chance of success of functionality of filtering bleb at 6 months. And the pattern should be multiple internal layers as well as microcyst. Now this is a Japanese study which was published, and in addition to what we have said, they also calculated the opening, filtering opening, which is seen from inside. And larger the opening, more is the success. That is what also they concluded. Now, two eyes can behave differently. These are the two eyes of one same patient. One has a large anoic area with a sponge here, and this is a huge bleb with just a spongy look. Now, early post, let me share this case. After 10 days, you can see the flap bleb. Few vessels are also coming up, tortuous vessels, and the pressure has started showing rise. So what to do? So should we remove the releasable suture? And this was the pre-release. You can see the uniform reflectivity of the bleb, almost flat bleb. Immediately after the releasing of the bleb, you can see the multiple layered subconjunctival separation and the anoic area on the suprascleral space. Now, the dreaded complication of use of mitomycin bleb is the leak or the hypotony and thin avascular area and likely to be blebitis. So the new technology modality is there. Allogen blebs are used to have a thick wall blebs. And what happens with these bleb? The natural history. The allogen implant is a biodegradable. By 3 to 6 months, it dissolves, leaving behind its space a fibrous sponge, a negative copy of the original one. I will share few cases of mine. First, if you see, this is immediately after the surgery. There is a allogen which is sitting here and this is the later phase. There is a shrinkage of the allogen later on, and the anoic area is coming up exactly on the top of the sclera. And these are few microcystic areas. This is after 6 months of the surgery. Now this is day 1, clear zone on the side of the allogen and homogeneous appearance here. This is after 3 months. Something is coming up. There is a shrinkage, height has decreased, and the clear area is coming up here. And at the end of 6 months, good anoic areas, aqueous pockets are coming up, lamellar separation is coming up, but uniform reflectivity is on the top. So shrinkage will leave behind the aqueous pockets underneath the bleb wall. So it is not a thin bleb like mitomycin, but good healthy bleb with a good filtering areas. And expression, you can see where is the position of the tube, a stent, and how good is the bleb. And the tenon cyst, you can identify whether it is successful after the needling procedure. So for me, implication of AIOCT is to identify the internal structure of the bleb, thereby providing better understanding of bleb morphology. It can predict its success or failure at early postoperative period. So we have a scope of early intervention in the bleb with a poor functional outcome. So the limitation, as I said in the beginning, vascularity of bleb cannot be seen. Leaking, sometimes if you can correctly place it in that particular area, you can see the break. And the longer duration follow-ups are required. That is the limitation. Thank you very much for your patience here. if you have any questions, we can take up now. The next speaker is now unbiased view, whether what is the present day status of this imaging, that Dr. Paul is going to. I've shown you in one of my chart. Wherever is the highest.
He's asking whether you have a video, like somebody is taking a video, how you are taking the picture of the patients. Like someone else is taking a video.
Imaging, there are options available in the Visante. You can take cross section from the maximum elevation in the center of the blab. One is vertical and the second is radial, perpendicular to the limbal, away from the limbus, but where is the highest elevation. Two sections you have to take, cross. So now Dipanjal will give us the unbiased view. What is the present day status? Where should we use this technology? And
ये आगे पीछे कहाँ पे करना है?
nothing. What happened?
ये कहाँ आ गया?
It is available with the other PSOCT as a, it comes as a duo. Yes, they do have. I am using Zeiss. She has used Topcon.
You get a corneal view also. Exactly you can't get. Color picture you can get it exactly.
In all the technology, there are options to, you can go with the grayscale or you can go with the hot colors. That options are there in the software.